Well, thanks so much for joining me today for episode 12 of season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to again begin by acknowledging and thanking the SCAN Group, the parent organization of the medical group for which I work, Healthcare in Action, for funding and supporting this podcast. Very much appreciated. And also wanted to give a shout out this week to SCAN for giving 10 college scholarships to Long Beach State University students who are in the health profession. So really great to see them giving back to the community. And just want to highlight that my views expressed in this podcast are my own, don't represent those of either Healthcare in Action or the SCAN Group. So my guest today is someone I'm very honored to have. He is the lead author of what, in my opinion, is the most important health policy study published in the last 20 years, at least, with respect to United States healthcare policy. His work has shown that there is extreme variability in how healthcare is practiced in different parts of the country. So where you live, and specifically the number of doctors there are in a particular region, is a huge driver of how much care you get. Simply put, the more doctors, the more visits that you are likely to receive. And this also applies to procedures like invasive procedures such as peripheral arterial revascularization. If you live in a region with a lot of vascular surgeons, you are much more likely to get these procedures. And what Dr. Fisher's research has shown is not only is there variability, but regions of the country with lower rates of healthcare utilization have as good, or even in some cases a little better, outcomes than those higher utilizing regions of the country. So it's a really fun discussion. We'll get a chance to talk it through with Dr. Fisher, so stick around for that. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to friends, family, and others who might be interested. Leave a review if you have a chance, and search for my YouTube channel, Healthy Skeptic MD. Okay, before Dr. Fisher joins us, as always, let's start with a rundown of the health news of the week. And of course, the big news this week is that the FDA advisory panel voted nearly unanimously, 17-0 with one abstention, to do an emergency use authorization for the Pfizer COVID-19 vaccine in children 5 to 11 in that age category. So I have a few comments on that. The first thing is I think it's really, really good news that the vaccine is now available to a broader population of people who want it. A lot of parents who want to get their younger children vaccinated, and I think it's great that it's available. The second thing, I agree completely with the advisory committee that the vaccine is very, very safe, and this is based not just on the several thousand of children in the 5 to 11 age category in this particular study, but on the hundreds of millions of people who have gotten the vaccine worldwide. And, with each passing day, our confidence in the safety of the vaccine grows stronger. So that's great. I also agree with the FDA's decision to do this as an emergency use authorization rather than a formal approval. Simply put, the vaccine has not been demonstrated yet to improve complications of COVID-19. It clearly is safe. It prevents infections. But what we really care about, does it keep kids out of the hospital and getting serious complications? And because these complications are so rare in kids, that's going to be a very difficult thing to prove. And, from an individual perspective, it just highlights that it really is a close call in kids in terms of the benefits and risks, and emergency use authorization does make sense given that. That brings me to the fourth point. There were several members of the advisory committee that expressed concerns that this authorization was going to result in policymakers implementing mandates, particularly in schools for young children. And the chair of the committee, Dr. Peter Marks, emphasized that in general, emergency use authorization shouldn't lead to mandates, in contrast to approvals, in which case it might be appropriate. I agree that's how it should be, but here in Los Angeles, that's a bit of a sensitive subject because the LA Unified School District, which is the second largest in the country, actually has placed a mandate based on an emergency use authorization currently in place for the 12 to 16 category. And they have implied that it will also apply now that the emergency use authorization is available for younger children. Now, I do have 3 children in this age category, 5 to 11 in LA Unified Schools. And, we will give the vaccine to our kids because I want our kids to go to school, and I am very confident about its safety. But I am sympathetic to parents who are concerned about this mandate. We've already seen in the 12 to 16 category a lot of kids in LA Unified not go to the schools because of this mandate. They're going to private schools, they're doing homeschooling and other things, including possibly not even getting school at all. So, my preference would have been for policymakers here in Los Angeles, and I hope others nationwide will wait until there is a little stronger data, a little more follow-up, and a formal FDA approval before implementing mandates in kids. So the second study I want to touch on is a very important study in the New England Journal of Medicine published a couple of weeks ago about depression. So a very common situation is someone who has had depression, chronic depression, and they've been successfully treated with an antidepressant and they're doing very well. And they're interested in stopping that medication. This comes up all the time in my primary care practice. And this study compared the outcomes of patients who continued the antidepressant medication versus those who tried to taper off it. Now, after a year, what the study showed is that 56% of the patients who tapered the medication unfortunately did experience a relapse of their depression symptoms versus 39% who did just continue the drug. Now, the take home here isn't that you shouldn't think about or try to taper off an antidepressant medication. It's always appropriate and reasonable to give it a try, give it a shot. But it is important to be prepared. So if you are going to try to taper, and particularly if it's been a chronic issue for you, you should be prepared to, and you should get psychotherapy, make sure that all the appropriate social supports are in your life, exercise, get appropriate sleep and rest, and do all those other important things that really help keep stabilized. And also be prepared that if it doesn't go well, you may need to restart the medication. But this study, I think, does provide important insights that may help guide the right decision for people in this common situation. So that's it for the news summary. Let's jump into our interview with Dr. Elliott Fisher. Thank you for joining the Healthy Skeptic MD, Dr. Elliott Fisher.
Such a treat to be with you. I'm glad to be here.
Well, as I was telling you before, it's a real honor. I've been following your work since I was starting my medical training experience, and you've had a huge influence on my development and thinking about health policy and healthcare as well, direct medical care, as we'll talk about. But if you could just begin by giving our listeners a little bit of a background about your career and what you do.
Sure. So I actually had no idea that I'd end up in medicine when I was in college. My father cast a long shadow. He was in law, and so I became a mountain climber. And then after graduating from college, decided to drive an ambulance in Somerville, Massachusetts, where two things happened. One is I found I really enjoyed taking care of people, and secondly, I saw that the poverty that was affecting that community at that time was devastating. And so I took both of those ideas and decided to go to medical school with a clear goal of being involved in research and policy to try to do something about the disparities that plagued this country then and now. So, from there, I went to medical school, trained in Seattle, worked in the public hospital there and in the VA hospital. Spent 2 years getting some training in how to do research and actually did some policy work during that time, and then moved to Dartmouth. In 1986 to work with this guy, Jack Wenberg, who had studied the healthcare in Vermont in the 1970s and showed that there were dramatic differences across in how people were treated across the very similar communities where people lived in Vermont. So almost twofold differences in the likelihood of getting something as simple as a tonsillectomy, and big differences in per capita spending. So I wanted to come. I thought this guy was asking amazing questions. As a medical student, it was inconceivable to me that there could be that much disagreement among physicians. I thought this was supposed to be a scientific enterprise. And so I luckily came to work with Jack, who was willing to have me. Spent 20 years practicing primary care medicine at our local wonderful VA and exploring the causes of variations in practice and spending across the United States.
And those variations are documented in something called the Dartmouth Atlas of Healthcare, which I think is perhaps the most important tool in health policy that a lot of people have never heard of. A lot of us health wonks have heard of and pay very close attention to it, but less so the general lay public. Could you tell us what the Atlas is and what it tells us?
Sure. The Dartmouth Atlas of Healthcare was an effort to try to compare how healthcare is practiced and how much money is spent on healthcare across the whole United States. So we divided the country up into about 300 regions where everyone who lived in those regions got all of their care from the providers within that region. So Seattle is one market, Eastern Massachusetts is another, and Minneapolis, Miami. And we had data on all of Medicare, all Medicare enrollees in each of those markets, and it allowed us to compare how care was delivered across the country. And because we had pretty good detail about the characteristics of each Medicare enrollee, we could make fair comparisons. So there are three big pieces of the work of the Atlas. One is exploring the causes of variations. Some was due to differences in patient needs, maybe 10 to 15, 20% of it. But most of the variations, as was true in Vermont, were caused by differences in the numbers of physicians, the supply of hospital beds and nursing homes, and really importantly, the decisions made by physicians. And we found big differences. Residents of Miami were getting about twice as much care as residents of Minneapolis. So that was the first. What's going on to explain that? The second was providing data to others so that they can continue this work of comparing what's happening in the United States. Anyone who wants to get on the website, just Google Dartmouth Atlas of Healthcare and you'll find it. And then the third piece of the work was informing policy.
You said it before, there are really striking differences and variations. Certain regions of the country that are doing cardiac procedures and colonoscopies and tonsillectomies at much different rates. I remember reading the Dartmouth, the Atlas first as a medical trainee, and it was just at a time when I was starting to see those variations, even at a micro level. We'd have one attending one day who would treat a patient a certain way, and then they would shift and a new doctor would come in and the plan would be totally different. And I also had that idyllic belief that this was all in a science and that there shouldn't be this much variation. So that's what the Atlas showed us with Wenberg. And then in 2003, you sort of took it to the next level. You published a paper that really showed the implications of those variations in care. It's a very detailed and important paper. Could you try to distill the key findings at a layperson level?
Yeah, no, it was a great project. I was incredibly fortunate. We'd shown the variations, and everyone in America assumed that the places that were getting more medical care were getting better health outcomes. But the differences were big enough that it was worth trying to figure out whether that was true. And so we really set out to understand what people were getting in the higher spending regions. And there were a few key analyses or questions that we looked at. The first question was, what are they getting in the higher spending regions? Are they getting more of the kinds of evidence-based things that we deliver in clinical care? Were they getting better control of their high blood pressure? Were they getting the right medications when they had a heart attack? Were they getting better screened? Were they getting more screening for the stuff that we know where there's strong evidence? Were they getting any more of that? Nope. They were not getting any more of the services that we know are beneficial. Second really interesting question was, are they getting more major surgery, elective procedures like cardiac bypass or joint replacements? And they weren't getting any more of those, which was something of a surprise. But what they were getting was more of what we refer to as supply-sensitive care, and I have continued to refer to it that way. So if you have more physicians in your community, you're going to get more visits to physicians. If there are twice as many cardiologists in a community per capita, there'll be about twice as many visits on average per capita with cardiologists. So that's one thing they're getting. They're getting more visits. They were spending a lot more time in the hospital. There are more hospital beds in the high spending regions. They were spending more time in the intensive care unit. In the first year after a heart attack, with detailed controls for how sick people were, you would spend 70% more time in the ICU or in the hospital in the first year after your heart attack compared to identical patients in low spending regions. And we had divided the country up into fifths, so that's the top fifth getting 70% more than the bottom fifth. So And if you're horizontal and in a bed and seeing more doctors more frequently, you're going to get more tests and minor procedures, that's the more that people were getting. So that was a really important insight, that the extra spending was going for stuff, for those kinds of services. But what we also found was that the outcomes were no better. Survival was no better. The quality of care measured by all sorts of measures that we had was no better. In any, to some extent, it was actually worse. And functional status was no better in patients cared for in the high spending regions compared to the low spending regions. So the takeaway was that, we were wasting between 25 and 30% of U.S. healthcare spending on services of no proven benefit in the high spending regions.
So a couple follow-up questions for you there. To the first point, what you're sort of saying is that if your tool is a hammer, the whole world looks like a nail. And that's something that I remember seeing as a medical trainee. If the attending physician was a cardiologist, they were always thinking about the heart, and the patient was more likely to get cardiac procedures. And if it was a pulmonary specialist, they'd always be thinking, oh, the lungs are the problem, and this is the service that I need to do. Is there some component of truth to that?
Physicians, I think all of us believe that we can do well and benefit our patients by seeing them. We all have a particular perspective through which we see the world. And, there are many good things we can do. The challenge is, and I think your podcast, I'm sure, focuses on this a fair bit, is that the evidence in favor, the evidence behind much of what we do in medicine is not so precise that it can tell you exactly what to do in every situation. There are many situations where we do know exactly what to do. Blood pressure control is really important. If you've broken your hip, gosh, let's fix your hip. My father had a dissection of his, of the big blood vessel that comes out of his heart, the aorta, and the surgeon saved his life. So there's all sorts of stuff we do that's great. And then there's so much of medical care is about either procedures or medications which really haven't been proven to be more effective than others. So the evidence is not very strong. And then, should I see a patient in a week or 2 weeks? There's no evidence to tell us that. But if we have an empty spot in our schedules, we will make sure that empty spot is filled. And so if you compare patients in Oregon, which is among the lowest spending regions in the country, they will see a patient with well-controlled high blood pressure once or twice a year. In Miami, according to our interviews, they'll do it every month. They will see that patient with well-controlled high blood pressure every month. So that's the area of practice variation where there are incredible opportunities for us to both improve care, because who wants to waste their time going to see the doctor 12 times a year for well-controlled blood pressure? And we can manage blood pressure pretty well with the telephone and giving you a blood pressure cuff. So that's where all the variation was, and where the opportunity to innovate to improve care lies.
So the second part of the finding was on the outcomes, and I think that came as a surprise to many, that more care didn't necessarily lead to better health. It's a little bit of a counterintuitive finding. Was that surprising for you? Were you expecting to find that higher spending regions triggered or led to better health?
I was not actually surprised. A colleague and I had written a piece about the harms of too much medical care a few years before that. Came out before we started this study, and that came out in JAMA. There are all sorts of ways that medical care can be harmful. If you don't need to be in the hospital, hospitals are not safe places to be. You can get a hospital-acquired infection. Elderly patients especially, can get disoriented. So hospitals, if you can be safely cared for at home with telephone calls with your provider or a few outpatient visits, it's safer for you. So I was not particularly surprised that we did not find better outcomes, because where we knew what the right thing to do was, you should get this medication, you should treat a patient with a heart attack a certain way. That was done similarly, not perfectly everywhere across the country, but everybody was trying hard to do the right thing all over the country where we knew what the right thing to do was. it was in these judgment call gray areas, judgment call areas where people were getting more. And, there are real harms from getting too many diagnostic tests, spending too much time in a hospital.
So these are very thought-provoking conclusions, and not maybe you might have expected it, I might have expected it, but certainly not what many people would have expected. But what are the implications of this? They're interesting, provocative findings, but how should that influence the way we think about healthcare, and what reforms are needed?
Well, I think there are a bunch of really important takeaways. The first is it will be really useful, even for you as a patient, to distinguish a biomedical decision, a treatment decision about whether and how to intervene for a particular clinical problem. Take early stage breast cancer. That's about, what's the right way to treat it? What are the right medications? There's lots of good scientific evidence that should help you understand how to make a wise choice there. There are other kinds of decisions, how care is delivered. That's where there's not a lot of great evidence, and where you may want to think as a patient, gee, doc, do I need to come see you every month to do this? Could we touch base by phone? Healthcare is expensive, especially increasingly so. So the how, by whom, do I need to see a specialist or not? How many specialists do I need to have? Those are places where patients may be able to have some more influence.
You've used the term preference-sensitive care to describe those types of services.
That's one of the other key takeaways, is really that for big, high-stakes decisions, like a joint replacement, take hip or knee replacement, the most common elective procedures performed in the United States. Hundreds of thousands per year. Those actually have some trade-offs involved in when you decide to get that procedure, how early in your course you need to get it. I was first recommended having my hip replaced 12 years before I decided to get it replaced. And what I learned at that point in facing my own high-stakes decision about a procedure that can be incredibly effective, that there were alternatives to getting the surgery early. I could do physical therapy to strengthen the muscles around my hip, which markedly reduced the pain I was having, so that I could delay the procedure, as I told you, 12 years. There are some risks, even when you do have the procedure, there are some risks. There's serious risks of infection in the joint, which then can be a pain and can be really difficult to fix, and maybe not be successfully repaired. Joint replacement has to be done again often if you live 10 or 20 years. Depends a little bit on the prosthesis. But so the decision about when to have a joint replacement really should be based on a fully informed set of full information about what your alternatives are. And they're useful tools called decision aids, which you can ask your provider for, that give balanced information from the literature that help you choose, understand the risks and benefits and trade-offs, and then have a discussion about what you really want. The challenge in American healthcare is that there are powerful financial incentives to do these procedures, and many orthopedic surgeons, as did mine 12 years before I agreed to it, think we should get the procedure. It's also really important to understand that some people are unnecessarily fearful of having a joint replacement. This has been recognized to be a particularly important problem for Black patients who tend to be distrustful of the American healthcare system, and we now know that they tend to delay getting surgery to a point where it's harder to do an effective joint repair. So this idea of shared decision-making and preference-sensitive care is not about doing less. It is about helping people make well-informed decisions. And what we now know is that on average, among white patients, they tend to choose fewer than their orthopedic surgeons would recommend. And on average, for Black patients, at least for Black men in the trials that have been done, they are more likely to choose to have a joint replacement when they understand the risks and have gotten information that lets them to be confident and trustful and have trust in the system that's delivering their care.
So I think it's a really important point. I think, if someone just reads the headline, they might think the implication is we just do too much, we should do less across the board. But I think what you're saying is there's a lot of patients who get too much excessive care, but there's also a lot who don't get appropriate evidence-based care, and it's really a mismatch. Maybe on the whole we do too much, but it's not as simple as just across-the-board cuts that we need.
Absolutely. Now, that other category we talked about, supply-sensitive care, is somewhat of a different story, right? This notion that there's so much care where we really have no idea whether it's beneficial or not, and we're not even organizing care to deliver it to you, the public, efficiently in ways that you would really like to receive the care. So how many specialists should you see? The biggest difference between high and low spending regions is that you are 6 times more likely, 60% more likely to have 10 or more different specialists involved in your care if you're in a high spending region than in a low spending region. And when there are lots of docs in your care, just as when there are too many cooks in the kitchen, it's really hard to coordinate and deliver effective, safe care. And so I think another challenge we face is organizing care in ways that lets us make sure we're delivering the best possible care, that the team that's taking care of you is integrated, coordinated, and can make sure you're only getting the care you need.
So I'm a primary care doctor. I was particularly struck by the variation, how often for high blood pressure those visits occur, anywhere from a month to once a year. I'm probably somewhere in the middle there, but how are we supposed to know what the right answer is there?
Oh, the right answer is your blood pressure should be controlled. Mm-hmm. and patients can, it depends, but many patients can monitor their blood pressure at home. A nurse can check in on them, once a month, and you don't have to take a day off from work and spend $150 on I don't know what anyone with a high deductible plan, they'll pay that whole thing. So we could design care that meets your needs, which is you should get your preventive services, you should get your chronic diseases well managed, but we can do it at much less burden and cost to the public. But that's going to require some changes.
And I think the high stakes decisions are also really important to consider, because things like a peripheral artery revascularization, which is something we've talked about, very invasive procedure, there's sometimes a 2-fold or 3-fold difference based on the Atlas findings about how likely you are based on where you live, not the symptoms you have or anything else, just based on simply where you live, how likely you are to get that procedure.
There's a lot we can do to keep people healthy. And then there's a lot of overuse because the current payment system rewards hospitals and physicians lavishly for doing procedures, with powerful incentives applied by the hospitals to encourage specialists to do more, see more patients and do more procedures, because that's how they break even and make their money. And you as a consumer should understand those incentives and be careful. It's only a fraction of the population right now that's getting care under systems where there are incentives to deliver great care, not just more care.
So your work has also had a lot of policy implications. It actually had a lot of influence in the Affordable Care Act and some of the programs. And there's a program in particular called Accountable Care Organizations, which some people may have heard tossed around. You're often credited as being the person who coined the term with a team of colleagues. Could you tell us a little bit, what is an accountable care organization, and why does the work you've done support that concept?
Yeah, so it's a great question, and it was great fun. And by the way, it's the Glenn Hackbarth, who was chair of the Medicare Payment Advisory Commission, and I came up with the term when I gave a presentation to this commission, recommending a new way of delivering and paying for care for the Medicare program. And we came up together with, he proposed the term accountable organizations, and I said, Glenn, let's stick care in the middle. And accountable care organizations. So the basic notion is that we have a current system which is challenged by this degree of fragmentation that I mentioned already. Each service is paid for individually to each physician and hospital, and there are no incentives to coordinate care across it. And there are incentives to do more, as I mentioned. There are no incentives and no accountability for the quality of care that patients are supposed to receive. And we knew of better systems. So integrated delivery. Kaiser Permanente, for those of you in California and in some other regions of the country, is a different way of organizing care. It's an integrated system where all of the physicians work together in a single organization as employees of that organization, and they get an annual payment. It's also an insurance program. They get an annual payment for all of your care. This gives them incentives to keep you healthy because it costs them more if you're sick, and it gives them powerful tools for coordinating care effectively. What the Accountable Care Organization model did was to say, how can we help American physicians and American medicine transition toward a system where they will have incentives to improve quality, and if they improve quality, they'll get a share of any savings that they're able to achieve. And that was the concept of accountable care organizations. It was included in the Affordable Care Act, and now both Medicare and many commercial health plans have contracts with their provider groups based on this model. It's about 30 million Americans that are now getting care in accountable care organizations.
Right. So it's basically trying to take some of the positive incentives that systems like Kaiser have and apply it to less integrated systems so that others can have the benefits. One of the concerns, of course, is that it's going to overcorrect and that it may incentivize doctors to provide too little care. But one of the nice things is it's balanced out with quality incentives and so forth. And it's that yin and yang balance that you have to get right.
Exactly. And the first round of managed care reforms back in the early 80s had no quality measures, and there were terrible fears of rationing. So far, there's no evidence of rationing under accountable care organization contracts. In fact, the evidence is they really are improving quality. It's the savings that haven't been as big as we hoped for. There's some modest savings, but quality measures in ACOs have really improved. So there's some real positives there. I think there's some challenges that still need to be overcome. It's hard if half of your patients are fee-for-service and half of your patients are under this new incentive. It's very hard to change all of your care to do well. So that we should, I believe, be moving toward more of a single payment model that all physician groups would work under, where then they would have powerful incentives to innovate and improve care for all of us.
And that's one thing I actually have noticed in your writing the last several years is that your sort of recommendations have evolved to how do we create more efficient systems so that incentives are better aligned. And one of the things that you've proposed is a single system solution, basically to try to reduce some of the complexity when we have so many different payers and some patients are in fee-for-service and some patients are in managed care. What is a single system solution?
Well, I think there are a few pieces of it. One piece is we need a single information system. I'm sure we've already talked about the lack of adequate evidence on many treatments and procedures, and part of that is because we don't take advantage of all of the data that we have to measure performance, measure the quality of devices or drugs more effectively, to better understand side effects, especially for subpopulations. And we don't take advantage of the care that the current delivery system is providing to measure the quality of providers for all of their patients so that we could all make much better informed choices among drugs, among providers, and among health plans. So the single information system is probably the most important piece of that idea. But the second part is that the system is so complex that if we organized physicians and hospitals into integrated, moderately sized medical groups, then we could measure their quality really well. And we as consumers might have 20 or 30 medical groups in our region, depending on the large or smaller regions. Tiny community, it might only be one if you're in a rural area. But you could understand its quality and know how good it was compared to the place 30 miles away. So organizing groups so that we can put every provider in a group and compare them, and then create a market where we as individuals can choose which group do we want to go to, and good enough measures about specialists to choose which specialists do we want to see, who's going to be safe, effective, and save us some money. So that's the fundamental notion. Single system was chosen specifically because I wanted to contrast it with single payer. It could be done under a single payer system, as in the UK or Denmark, but it could also be done under a better regulated system where insurers and providers all operated under the same set of rules to allow us to make choices and have the market function to improve quality and reduce costs.
Yeah, I actually had as a guest a few months ago on this podcast, Steffi Woolhandler and David Himmelstein, who made a very compelling case for a single payer system. And, their case was that really the payment system is really the opportunity to integrate it all. And I agree, in an ideal world that makes a lot of sense. But there's also a lot of interests out there, and I think what you're proposing is that there's potentially other creative ways to get some of the benefits of a single payer system without doing that.
Yeah, I was not confident that we could overcome the entrenched political interests of the current system to eliminate insurers, and that. So I wanted to present, especially as the Biden administration was coming in, an alternative that said, but we could still get tremendous value of the principles of single payer in a regulated multi-payer system, as they do in the Netherlands.
Yeah, and I think we're all on the same page that we just got to simplify it, and it makes a lot of these things clearer. The other thing that in your more recent writing you focused a lot on are health-related social factors, or sometimes called social determinants of health. And, there's some data that the medical services we do are only responsible for 10% of someone's overall health. And it's really these social factors that are 30%, 40% or more of the story here. And so you've tried to integrate, ways to incentivize a greater focus on these health-related social services. Could you talk a little bit about your views on this?
Yeah, first, it's really over the last, people have been talking about the importance of social factors since the beginning of the 19th century, when we realized that giving people safe water was life-saving. But over the last 30 years, there's been a much greater recognition of the many social factors that directly influence people's health. We all are quite familiar with the importance of lifestyle choices, whether you're a smoker, your diet, your exercise, all those things, across the lifespan of a typical American would account for almost 10 years of difference in life expectancy from people who, if we got rid of all those risks that could be modified. But what we know is many of those behavioral determinants and many other determinants of health are fundamentally about the social structures within which we live: poverty, inadequate education, a physical environment that exposes some people to allergens and pollution, stressors. Stress is well recognized now to cause early aging. So there's a set of social factors that lead to differences in life expectancy across counties in the United States of almost 20 years, and within cities. So you can go from one zip code in Chicago on the west side to next to the lake and have a 20-year difference in life expectancy based on where you live within Chicago. Same is true in New York City. So, and then, layer on top of that systemic racism and the consequences of on the health of Black populations due to the discrimination they've experienced, and the systemic causes that put them at particular disadvantage, but also to the stresses. We know that maternal outcomes among Black women, even wealthy Black women, are substantially worse than among the poorest white women. So a lot of social factors, if we paid attention to them, we could dramatically reduce the disparities that we see across communities and give everybody a much better start in life and improve the productivity of the United States substantially. So there's a huge amount that could be done. There are some policy initiatives that people are undertaking to try to get communities to work across stakeholders. Accountable Health Communities, an initiative promoted by the Medicare program, by the Centers for Medicare and Medicaid Services, although that is mostly targeted on screening for social needs. But there are now, we think, 400 communities across the United States that have multi-stakeholder coalitions trying to think about the fundamental causes of poor health in their communities and what could be done to enable everyone to thrive in the United States. That's about decent education, anti-poverty programs, educational opportunities for everyone, jobs, and we're confident that those kinds of investments could dramatically improve the health of all Americans.
Yeah, I just want to acknowledge that you also had a role in developing the concept of an accountable health community, which is really trying to do something analogous to the accountable care organization, where a group of healthcare providers are accountable for their population, to take that to the community level and say, a community is accountable for the health of their population, because in a lot of ways, as you said, that the community level can have as big or bigger impact as the medical system.
And they can hold the hospitals and accountable care organizations accountable themselves to make care cheaper and better.
That is a tricky one to implement, but looking forward to seeing how that turns out. I did want to conclude, Elliott, with a couple questions down at the micro level. Our audience is mainly lay listeners, and you started talking about this before, but we know there's a lot of waste. We also know that there's a lot of procedures that people should get that they don't get, probably more of the waste, but nevertheless, there's some of both. What are the implications from your work, for an individual consumer? How should it influence your thinking when you step into the doctor's office?
Oh, what a great question. Buyer beware. I think there's a podcast you should listen to called The Healthy Skeptic. There are tremendous, we all need healthcare. At some point, we're going to need it. And we can have a tremendous influence on what happens. I think going to your provider with an idea of what's really important to you. So the first question I wish all doctors would ask is, what matters to you? And there's a fairly strong consumer movement now, which is trying to get more and more patients to be very clear when they go in about what their interests are, what they want to achieve from this encounter. And set the agenda at the outset of the meeting. Don't let the physician interrupt you at 7 seconds, as they tend to, but say, let's talk for a second about what we're going to try to accomplish during this visit. It's your visit. I think the next thing that all of our work would suggest is that where you have a choice of a clinical treatment, ask your clinician, can they provide you simple, easy to understand information on the risks, benefits, and costs of the treatment alternatives. They recommend something, you can ask, that sounds great, doc, tell me a bit more. What are the benefits of this? This is this concept of shared decision making, of working together with your provider to make an informed choice based upon what's important to you. There's some people who have symptoms that doctors believe they can eliminate, but those symptoms don't bother the patient. It's hard to make someone who's not bothered by something better. So you need to know, yes, I've got this. Do I need to worry about it, doc? Is this a life-threatening thing? Or can I learn to live with it? Because it really doesn't bother me very much. And if it's about getting a major surgical procedure, maybe I can delay that for a while. Back pain would be a wonderful place to exercise that responsible ownership of your own condition. There's great evidence that most back pain resolves on its own. Surgical interventions early in the course of serious back pain, even serious back pain, do not make it better. So understand the risks and benefits of those alternatives and work with your clinician to make an informed choice about what's best for you.
And it also relates to the concept of second opinions, something I used to recoil a bit at, that, how could it, you don't want to question your doctor, but there is so much variation. There's more than one way to do it right. And you got to match, what your goals are with the treatment options. And so maybe it is okay to get second opinions.
Oh, I think it's tremendously important, especially for very high stakes decisions. So saying, thank you, doc. That's a great idea. Since this is not a decision we need to make in this instant, I think I'm going to seek a second opinion. The challenge of our current system is that the payment system makes it expensive to go get a second opinion, especially with high deductible health plans. So my apologies that we haven't yet fixed that for you. High deductible health plans were a nutty idea when introduced, and it's our responsibility to get it better. But because even if you have a high deductible health plan, getting a second opinion could spare you from a $10,000 procedure. So it's maybe worth getting it, even if you have to pay for it.
Well, your answer there really reminded me of something that Kevin Grumbach said. He's the chair of family medicine at UCSF, and he was talking about Michael Pollan's book about simple ways to eat healthy, which, in Michael Pollan's world, that was eat not too much, make it mostly plants. And so Kevin applied that to healthcare. Get healthcare, as you said, not too much, and make sure it's mostly primary care.
I absolutely love that line. It's great. Yes. Follow Kevin's advice.
Well, thank you so much for joining me today, Dr. Elliott Fisher. Real honor to have you on the show, and I've been following your work for a long time, so happy to be able to share your ideas with a broader audience. If you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to friends, family, and others who might be interested, and give it a review if you do have a chance. Thanks again, Elliott, for joining today.
Hey, it was wonderful to be with you, Mike. Thanks for having me.